presentation describes correct inhaler use for individuals who have obstructive airway disease. This includes asthma, chronic obstructive pulmonary disease, and cystic fibrosis. When a healthcare professional prescribes an inhaler, he or she has to make three distinct decisions. First, do I use a short or long-acting medication? Second, do I use a beta agonist or a muscarinic antagonist as the class of bronchodilator, or do I combine both? And then third, which is the appropriate delivery system? Today's presentation will focus on delivery system and correct inhaler use. This slide shows the 4 different delivery systems, which include metered dose inhaler, first available in 1955, the nebulizer therapy, predominantly available in 1964 and thereafter, dry powder inhaler, including the Discus, which was approved by the Food and Drug Administration in 2002, and the hand inhaler device approved by the Food and Drug Administration in 2003. And the 4th delivery system is the soft mist inhaler, which was approved by the Food and Drug Administration in 2014. A brief review of aerosol particle size and lung deposition. This slide shows a diagram of the upper and lower respiratory tract, and you can see on the right is a cross-section of the bronchus, and this red circle is the smooth muscle that wraps around the bronchus. The bronchiole on the bottom left is a smaller airway with the red representing smooth muscle. The point of this diagram and the bronchus and bronchiole is to demonstrate that an aerosol should be 5 micron or smaller in diameter in order to reach the lower respiratory tract, where it attaches to bronchial smooth muscle, causing relaxation and or prevention of bronchoconstriction. We have some challenges in correct inhaler use. First, current guidelines and strategies on COPD offer no specific recommendations on which delivery system to use, in which patient type, to achieve optimal clinical outcomes. In addition, there is well-documented errors that occur among patients using inhalers. This slide and the next one is a publication in the journal Chest 2016, which was a systematic review of 144 articles on inhalation technique that included over 54,000 subjects. The 3 major errors with pressurized meter dose inhalers were poor coordination, 45% of the time, inadequate speed and or depth of inhalation, 44%, and no breath holding in 46% of reports. There are also errors in dry powder inhaler use based on the same systematic review. 29% had incorrect preparation of the dry powder inhaler. 46% did not exhale completely before inhaling. And there was no breath hold in 37% of subjects. So the 2 basic principles on correct inhaler use that I will be promoting in this presentation are that different approaches are required for each delivery system, and the medication needs to be inhaled deep into the lower respiratory tract for benefit. Let's start with the pressurized metered dose inhaler shown here. On the left is a picture, and on the right is a diagram of its components. When the canister is depressed, aerosol is released, and with good technique, 20% of the aerosol reaches the lungs. Before using the pressurized metered dose inhaler, it needs to be primed. For priming, the inhaler should be shaken and pressed down on the canister to spray the aerosol into the air 3 to 4 times. The aerosol should be sprayed into the air away from any individual. Using the metered dose inhaler, shake the inhaler vigorously. Take the cap off of the mouthpiece. Hold the inhaler with a finger on the top of the canister, shown here, and a thumb at the bottom. 2 different techniques are available. One is the closed mouth technique, in which the individual exhales completely and then places the mouthpiece inside the mouth with lips closed. The other approach is called the open mouth technique. The individual exhales completely and then places the inhaler 2 fingers in front of the mouth. Either the closed or open mouth technique can be used. For using the metered dose inhaler, at the start of breathing in, press the canister down and release the aerosol. Continue to breathe in with a slow and steady effort. Fill the lungs with air. Hold the breath for 10 seconds or for as long as possible. 15 to 30 seconds, and then repeat the above steps. If the medication contains an inhaled corticosteroid, rinse the mouth with water, gargle, and then spit out the water. Some metered dose inhalers contain a dose counter demonstrating the number of doses in the inhaler. The metered dose inhaler should be cleaned at least once a week. To do this, remove the canister and clean the plastic case and cap by rinsing thoroughly with warm running water. Clear aerosol buildup from the spray nozzle. Allow the plastic case and cap to air dry. And also wipe the mouthpiece with a cloth. The metered dose inhaler may also be used with a spacer or holding chamber. The benefits of a spacer are it eliminates difficulty with coordination, that is, pressing down on the canister and then inhaling the aerosol. A spacer should be used. There are no differences in lung function comparing metered dose inhaler with or without a spacer if good technique is used. The spacer should be used with a metered dose inhaler if the individual has difficulty with coordination and if the metered dose inhaler contains an inhaled corticosteroid. To use the metered dose inhaler with a spacer, shake the inhaler vigorously. Take the cap off the mouthpiece. Place the inhaler into the end of the spacer, shown in the diagram. Breathe out completely away from the spacer, and then put the mouth around the mouthpiece of the spacer and close lips. Press down on the top of the canister to release the aerosol into the spacer. Then breathe in with a slow and steady effort. Fill the lungs with air. If you hear a whistle sound, you are breathing in too fast. Hold the breath for 10 seconds or for as long as possible. Then wait 15 to 30 seconds and repeat the above steps. If the medication contains an inhaled corticosteroid, rinse the mouth with water, gargle, and then spit out. The spacer should be cleaned periodically. To do this, wash the spacer with warm water and dishwashing detergent. Washing with water alone causes an electrostatic charge that reduces effectiveness of the spacer. Air dry overnight. Do not wipe or rub the inner surface of the spacer, as it adds to the charge inside the spacer. So, for review, if the metered dose inhaler is used with or without a spacer, the appropriate inhalational technique is slow and steady. The next delivery system I'm going to discuss is a soft mist inhaler, which delivers a slow-moving mist. And based on a study of 14 patients with COPD, 53% of the dose reaches the lower respiratory tract. This slide shows a diagram of the soft mist inhaler on the left and the nozzle on the right. Note, the bottom left is the cartridge which contains the medication. Above that is a spring. Above that is the dosing chamber. And above that is the nozzle, which is shown magnified on the right. The nozzle contains multiple microscopic outlets which provide the soft mist delivery. The soft mist inhaler should be primed, as also discussed with the metered dose inhaler. Recommendations are to release 4 doses of visible mist into the air before use. To do this, the first step is to turn the clear base, which loads the spring, to provide the energy needed for high pressure generation of the aerosol. The turn should be 180 degrees or half a turn. The next step is to open the cap. For priming, you would then press the button to release the mist into the air. After the device has been primed and to use correctly after turning and opening, then the individual should breathe out completely, press the button to release the mist, and inhale slow and steady. Hold the breath for 10 seconds or for as long as possible. Many of the soft mist inhalers require a second inhalation. To review appropriate use of the soft mist inhaler, remember TOP. T refers to turn the clear base. Open refers to open the cap and close your lips around the mouthpiece, and P or press the dose release button and then inhale. So for review, the soft mist inhaler, the individual should also use a slow and steady inhalation. There are 5 available dry powder inhalers approved for use in the United States. These include the Discus, the HandiHaler, the NeoHaler, the PressAir, and the Ellipta. The dates below each device is the year of approval by the U.S. Food and Drug Administration. Each dry powder inhaler has an internal resistance, which requires breath actuation. This slide shows the internal components of the Discus device, a widely used dry powder inhaler. Note at the bottom is this coiled strip, and the black gumdrop-shaped objects are pockets containing the medication. When the lever is pushed, the coil rotates and deposits the powder in the manifold. Above the manifold is an exit port which provides resistance to inhalation, and the mouthpiece is noted above. This slide shows the different internal resistances of the 5 dry powder inhaler devices. The NeoHaler has the lowest internal resistance. The HandiHaler has the highest internal resistance. To use a dry powder inhaler, the individual needs to breathe in hard and fast to generate an adequate inspiratory flow to break up the powder into small particles, less than 5 micron in diameter, that can be inhaled into the lungs. The recommendation is to measure the peak inspiratory flow rate against the simulated resistance of the dry powder inhaler being considered for prescription. Peak inspiratory flow rate can be measured by different devices. Shown here is one of these devices called the InCheck Dial G16. If the peak flow against the simulated resistance of the dry powder inhaler being considered is 60 liters a minute or greater, that is considered optimal for inhaling the powder out of the device. If the peak inspiratory flow rate is less than 30 liters per minute, that is considered insufficient. A peak inspiratory flow rate between 30 and 60 provides some but less than optimal benefit. The dry powder inhaler inhalational technique is hard and fast, as opposed to slow and steady with the metered dose inhaler and the soft mist inhaler. The fourth delivery system is the nebulized device, shown here. Indications for nebulized bronchodilator therapy are summarized in a recent publication in the Journal of COPD Foundation. One indication is cognitive or physical impairment, meaning this individual has some frailty or has difficulty with coordination. A second indication is persistent or unstable symptoms, a history of frequent exacerbations or hospitalizations. A third indication is a low peak inspiratory flow rate, as described before, so the individual is unable to optimally inhale powder out of the dry powder device. Another indication is laryngectomy present. Some patients prefer nebulization. They report that it seems to be more effective. And another reason is that the individual cannot afford handheld devices. So in summary, the major advantages of nebulized bronchodilator therapy are minimal coordination and effort are required. There's normal breathing in and out, and medications are usually covered by insurance. The disadvantages of this approach are an external power source is required. There is time for preparation and inhaling the medication, and fewer medications are currently available for nebulized therapy than available by the three other delivery systems. So, in summary, the appropriate inhalational technique with a nebulizer is normal breathing in and out. This is different than the inhalation approach with a dry powder inhaler, the soft mist inhaler, or the metered dose inhaler. The nebulizer should be cleaned after each use. Rinse the nebulizer cup, shown here, and the mouthpiece, shown here, with warm water and air dry. To make sure all parts are dry, run air through the nebulizer for about 20 seconds. The nebulizer should be disinfected once or twice a week. Remove the mouthpiece and the cup and soak these in a solution of 1 part vinegar and 3 parts hot water for 1 hour. Then remove the mouthpiece and the cup from the solution and allow to air dry. Correct inhaler use requires a personalized approach to prescription. The goal is the right medication in the right inhaler device for the right patient. If a metered dose inhaler or soft mist inhaler is being considered for prescription, review the inhalational technique with the patient and provide written instructions. At the follow-up visit, the healthcare professional should ask the patient, is the bronchodilator inhaler helping you to breathe easier? If it's not helping, then ask the patient to describe or show how he or she is using the device and review correct technique. For a dry powder inhaler being considered, The recommendation is to measure peak inspiratory flow rate against the simulated resistance of the dry powder inhaler being considered for prescription. If the peak inspiratory flow rate is equal to or greater than 60 liters a minute, it's reassuring and okay to prescribe the particular dry powder inhaler. If it's less than 60 liters a minute, it is concerning, and the healthcare professional should consider an alternative system. These are shown here: metered dose inhaler, soft mist inhaler, and nebulizer. For nebulized therapy, describe to the patient how a nebulizer works and provide written instructions. This slide summarizes correct inhaler use for each of the 4 delivery systems and the 4 inhalational strategies. Correct inhaler use is required for optimal benefit. Specific inhalation instructions should be provided for each delivery system.